Hello, thank you for coming. I'm Dr. Blair Rowitz with Carle Bariatrics, and let me welcome you to our Bariatric Informational Seminar. My goal is to teach. My goal is that when you leave tonight, you've heard everything that you think is important about weight loss surgery or bariatric surgery. I'm going to tell you the good, the bad, and everything in between, so if you're thinking about this type of procedure, you can use that as information to guide you towards a decision. Some of the things you hear today are going to sound wonderful, and that's because they really, truly are wonderful. Some of the things you hear tonight might be things that you don't necessarily want to hear, but again, that's my goal, is to give it to you straight, okay? Before we do that, before we talk about the surgeries, we have to talk about the disease itself, the disease of obesity. Obesity is a huge problem all throughout the world, but especially in the United States. Whereas 30% of people throughout the world are overweight, in the United States, over 60% of Americans are overweight. And that number is going up very rapidly and very drastically. 30% of our children are also overweight, and that is a number that's reaching really staggering or epidemic proportions. 15 million in the United States are what we call morbidly obese, or the point where your obesity begins to have a serious or a dangerous effect on your health. And it represents about 6% of all healthcare expenditures in the United States. And that's a lot of money when you think of all the money spent on healthcare in the United States. It's even more when you think about all the money that's not counted in that 6%. And that's all the things that we spend money on to help us try to lose weight. The latest diet book, or the latest exercise videos, or exercise machines. Most importantly, though, 400,000 people die every year from complications of obesity. That makes obesity the #2 cause of preventable death in the United States. So smoking is the #1 cause of preventable death in the United States. Obesity is #2, and obesity is catching up very rapidly. How do we decide when somebody's overweight? Well, in medicine, we use a number called the BMI, or the body mass index. What the BMI is, it's a number, it's a formula. And it's a fancy formula. We take a patient's weight in kilograms, we divide it by their height in meters squared, and that gives us a fancy number we call the BMI. And it's been shown over and over and over again in multiple medical studies that the higher a person's BMI, generally speaking, there are exceptions, but generally speaking, the higher a person's BMI, the more likely they are to have serious or dangerous medical problems associated with their obesity. So we use BMI to classify patients and to decide who might be candidates for surgeries or procedures by classifying based on risk. This is a chart here, and in this middle column that you see, this is BMI, or body mass index. And you notice that as your BMI goes up, as you go from these, through these classifications, your risk of comorbidities, that's an associated health problem, that also goes up. We say a normal body mass index is somewhere between 18 and 25, okay? So what does a normal body mass index mean? I mean, people can have a different opinion of what's a normal body weight. Well, they say, well, that's the weight you look the best, or that's the weight my clothes fit the best, or that's the weight that, you know, the most people are attracted to me, or there's lots of different opinions. But in medicine, when we say this is your ideal body weight, or this is a normal body mass index, what we're saying is this is the weight on average that you'll live the longest and healthiest. And it comes from insurance tables. So that when we say this is your ideal body weight, that's what we're talking about. A lot of times we'll tell patients, they'll say, what's my ideal body weight? We'll say, this is what it is. Well, I'll never look good at that body weight, right? But that's not what it's about, because that's the weight that you live the longest and the healthiest at. As you go through these classifications and your body weight gets higher, your risk goes up. To a point when you reach this body mass index right here in this bottom red column, when your body mass index is over 40, your risk of comorbidities or associated health problems becomes very severe. And so that's why we use BMI of 40 as a criteria for surgery. So we say that any patient with a body mass index greater than 40 potentially qualifies as a candidate for surgery. Okay, so people say, how much do I have to weigh to qualify for this operation? That's the answer. Your BMI has to be greater than 40. Now, we also make exceptions. If you're in this classification right here, if your body mass index is between 35 and 40, you still have a very severe risk of comorbidities, then you qualify if and only if you have a life-threatening medical problem associated with your obesity. And those would specifically be high blood pressure, diabetes, heart disease, cholesterol problems, or sleep apnea. So if you have one of those 5 problems, you qualify if you're in this BMI of 35 to 40 range. If your BMI is over 40, you potentially qualify even if you don't have those problems yet, because you're at high risk of developing those problems in the future. Here's a list of medical problems associated with your obesity, diabetes, high blood pressure, cholesterol problems, heart disease, sleep apnea. These are the ones we generally consider the life-threatening ones we just mentioned. But there's a whole list, and I could probably put a couple more pages and slides of other problems associated with obesity. And that's the reason we recommend surgery for people, is because many times, as we'll talk as we go on a little bit further, we can help with these medical problems. If you sum up the risk of the obesity together, that's what we have on this slide, the risk of the obesity compared to life expectancy. So what we have is a graph, okay? You remember we said at this part right here between BMI of 20 and 25, remember we said that's a normal body mass index? So if you look at this graph, going this way on the graph is body mass index. As you go to the right, your BMI gets higher, you get heavier, okay? As you go up, this is mortality ratio, or the relative risk of dying compared to somebody who's at the lowest risk. And so like we said, a normal BMI between 20 and 25. Well, what happens as your BMI goes up? What happens to your mortality risk? If you follow this line, your mortality risk also goes up to a point where when you reach a body mass index of 40, your relative mortality ratio is about 2.3 or 2.4 times higher than somebody who's a normal body weight. So that's a very serious risk, okay? That's a very serious risk. The problem is, for most people who are considering surgery, right, remember we said BMI of 40, that's generally the lowest criteria. Well, they're facing BMIs that are much higher than that, 50 or 55 or 60. And so when you get to those BMIs, your risk goes up even more substantially. So when you get to a risk of BMI of 50, let's say, if you're going to extrapolate on this graph, it's going to be way up here at the ceiling, your mortality risk. And so that's why we generally recommend surgery for people. So for the vast majority of people who are considering surgery, anytime we decide about an operation, we have to weigh the risk versus the benefits. Okay? For the vast majority of people, the potential benefits in terms of increasing health, improving life expectancy, by far outweigh the risks. How many folks in here, when you told your friends, your family, hey, I'm thinking about having that bariatric surgery, how many of them, your family members told you, don't do it? Hey, man, don't do it. Anybody heard that before? The argument is, isn't that risky surgery? Anybody heard that before? And the answer is yes, it is risky surgery. There are risks to the surgery. But for the vast majority of patients, the potential benefits outweigh the risks. And people who generally take that approach, they don't understand, well, what's the risk of not doing anything? And that's what you see with this graph right here, okay? All right, so we've already kind of hopefully made the argument that we need to get the weight off. What are the options to do that? What can we do to help people get their weight off? Well, the first thing is diet, exercise, behavior modification. Behavior modification, diet and exercise, that's self-explanatory, right? Behavior modification, that's things that help you change your behavior. That might be counseling, support groups, even things like hypnosis, all right? No question that's the place to start, but what's the problem with it? It doesn't work for most people. If you look at people facing a body mass index 40 or greater, the chances that they're going to lose weight and get to a healthy body weight and keep the weight off over the long run is less than 1 or 2% over 5 years or so, okay? So that means 98 or 99% of people who are battling this problem, who use this solution of diet and exercise and behavior modification, they fail. All right, so why do they fail? Does that mean that they're bad people, that they don't have willpower, that they're psychologically scarred and they just can't do it? Well, no, that means there's something wrong with the therapy, right? It means the therapy doesn't work. The problem is our bodies are genetically made to hang on to weight once we've gained it. It's probably a protective mechanism from a long time ago. And that's why losing weight becomes so difficult. The next thing to consider is medicines to help you try to lose weight. And there's lots of different medications, and they work in lots of different ways. There's some medications that that will help curb your appetite. There's some medications that will help you not absorb fat. So when you eat fat, it runs through you and you can't keep it down, and so that helps you lose weight. The problem with the medicines, again, long-term effects. Sometimes they can help in the short term, lose a little bit of weight, 10, 20, 30, 40 pounds. But to keep it off over the long term becomes the problem with the medicine. So they generally tend not to work real well. They generally tend to have pretty strong side effects, and most people can't stay on them for a long period of time. You know, the medicines that help you lose the fat, that, you know, they cause gastrointestinal upset and sometimes accidents and flatulence and things like that. Some of the other medicines, they work by increasing your metabolism. So what happens when you take those? Well, you're all jacked up, you're excited, you're irritable, you can't sleep. And so again, most people can't stay on the medications very long because of side effects. The other problem with the medicines is they're expensive, and most insurance companies will not pay for weight loss medicines. Why? Well, because they don't really work in the long term. So the next thing to consider is surgery, and that's what we're here to talk about. And you might be thinking, hey, I've been here all this time. He's finally going to talk about surgery. But before we talk about surgery, we have to discuss, well, what is the problem? What is the risk of not doing anything about the problem? And then what are the other options? And those are the other options other than surgery. And we're going to talk today about 3 operations. These are the 3 operations that we perform here at Carle: gastric bypass, sleeve gastrectomy, and laparoscopic adjustable gastric banding. We're going to start with the gastric bypass because that's been around the longest, and many people call it the quote-unquote the gold standard surgery because it's been around the longest. It's the thing we have the most experience to compare it to. With the gastric bypass, it tends to be generally a very effective operation. The average person will lose about 60 to 80%, not of their total body weight, but of their extra body weight. So if you're 100 pounds overweight, 60 to 80% of that 100 pounds. If you're 200 pounds overweight, so on and so forth. Most of the procedures can be done laparoscopically. That's through the scope with the small incisions. And when we do that, people tend to stay in the hospital with an uncomplicated course about 3 days. Some patients, we can't do the scope operations. About 85% of the time we can. Some patients, usually because of physical factors, sometimes being too large or multiple abdominal operations, that becomes difficult. We can still offer the open incisions. The average person with a laparoscopic gastric bypass will return to work in about 2 to 3 weeks. And if I was going to summarize it, we'll compare the operations. It is the most consistent weight loss between the 3 operations. It is the most effective average excess body weight loss. However, it is the highest risk, so there's a trade-off. Now, the way the operation works is what we do is we take a patient's stomach. This is your stomach right here. And normally your stomach's about the size of a small football, okay? And we're going to cut your stomach down and separate so that the part that holds food, this part right here, is only going to be about the size of an egg, okay? The reason we do that is because we create what we call restriction. If your stomach is only that big, right, your portion size can't be much bigger than that. Otherwise, you won't be able to tolerate it. You won't be able to eat it. We gain weight because we simply take in too many calories. We take in more calories than we burn off. And so if we can restrict how many calories you take in by restricting the size of your stomach, we can help you lose weight. That's the main way gastric bypass works, but it also works in some other ways. Another thing that we do is we divide the intestines down here. We take the side, we divide it, hook it back up here, and we make a second connection down in this area right here. The reason we do that is that we create a sort of a bad reaction or negative reinforcement if you drink liquid calories. So things like milkshakes, Coca-Colas, ice creams, sweet tea. If you drink those things, because of this intestinal bypass we've done, you get sick afterwards. We call it dumping syndrome. It comes on about 10 or 20 minutes after you drink those things. It lasts about 10 or 20 minutes after you drink those things. And guess what? When it happens, you realize, hey man, I don't want to do that. And you're forced to avoid those things. See, if we just restrict the side of the stomach, we won't do operations that restrict how much liquid a patient can take in because we need those liquids to survive every day. And so we won't restrict the liquids. By creating this reaction, if you drink the sugar liquids, then that prevents you from drinking those things. You can drink all the non-calorie liquids you want, and we encourage you to do so, and our nutritionists will talk to you about that. But if you drink the calorie liquids, you're going to feel sick or feel lousy. The other way the operation works is food will not come in contact with this part of the stomach anymore, called the fundus of the stomach. And there's been some studies and data to show that if you bypass that part of the stomach, it changes some of the hormone makeup of the intestinal juices and such that you feel full afterwards. So the first several months after a gastric bypass surgery, patients have a feeling of fullness and they don't want to eat as much, and that also helps with weight loss. And then there's some newer information studies that show if you bypass this part of the intestine right here, which we'll do, your food won't come in contact with that anymore, it will also help change your body's resistance to insulin, so it can help with diabetes in that fashion also. So a combination of all those things explains why gastric bypass helps people lose weight. So if you look at the results of gastric bypass, now I'm going to show you some results and on these slides, and these are individual studies. Sometimes the studies show a little bit better, sometimes they show maybe not such good results, but they all tend to center around these numbers, and that's why I've picked these numbers out. Okay? So if you look at people who are diabetic before their gastric bypass surgery, about 90% of people will get off their diabetes medicines completely. Okay? So it's actually potentially a cure for diabetes, and there really aren't any other cures out there. Cholesterol, patients with cholesterol problems, about 70% have significant improvement, get off their medicines. About 2/3 of patients get off their blood pressure medicines. Sleep apnea resolves about 90% of the time, and acid reflux resolves about 98% of the time. That's heartburn. So it tends to have excellent results in terms of these health problems and these comorbidities as well. Now, the lat band is another procedure that we offer here at Carle. And the way it works is we take a plastic band and we put it around the top of the stomach. It's called a lat band. And on the inside lining of the band is a balloon. It's a circular balloon and it's shaped like a lifesaver. I'll show you another picture here in just a second. And then that balloon attaches to a tubing, and that tubing attaches to a port that we implant underneath the skin, so can't see it, it's underneath the skin. And then down the road after the surgery, we can take a needle in our office and inject saline in and blow that lifesaver balloon up and make it tighter, or looser if it needs to be. And that's how we can help create restriction and control portion size. The lat band, the average excess body weight is about 50% at 3 years. So it is less than gastric bypass. You saw that 60 to 80%. It is a little bit less, but it also takes longer. So if you have a lat band, you have to be more patient. It takes about 3 years to get your maximum body weight loss, as opposed to 1 year or so with the other operations. It involves just an overnight hospital stay. In fact, nowadays, most of our patients we're doing as an outpatient. So most people don't even stay in the hospital after lat band surgery. And most people can be back to work in about a week to 10 days. I compare the recovery if you've had gallbladder surgery, elective gallbladder surgery. I compare the recovery to that. If you've had that done, you know somebody's had that done. Then what we do with the lat band is we have to see you back in the office periodically to check to make sure that band is appropriately tightened. And we will see you about every 6 to 8 weeks for the first couple of years after your surgery, so that we can make sure that you have just enough restriction that your portion sizes are small, yet you're able to get enough nutrition and enough fluids down. If I were going to summarize compared to the other two operations, it is the lowest risk. The chances of dangerous, life-threatening complications with lat band are very unusual. But it is the least consistent among the three in terms of the weight loss. So again, it's a trade-off. Lower risk for maybe not as consistent weight loss as the other operations. So this is the band right here. This is the part that goes around the stomach. And that's the tubing that's inside the abdomen, that curly Q right there. And then that right there, that's the port that sits underneath the skin. And again, it's deep enough that you can't feel it. We can feel it in our office by pushing real hard on your belly, and that's how we know where to stick the needle to inject it. And again, this is what the lat band looks like when it's empty. So you can see it's nice and wide open, and food and things will pass through. When your band is empty and it's not inflated, it's basically like eating without having the band. But as we tighten it up, you can see the opening for food to pass through becomes more narrow, and again, that's what helps create restriction. If you look at the improvement in medical problems, diabetes tends to improve in most of our patients, but to really resolve in only about 50%. So it's not quite as high as with gastric bypass. Cholesterol, same thing, about 50%, blood pressure about 60%, and sleep apnea about 90%. So again, that's really good. 50% cure for diabetes is still very, very good, but it's not quite as high as the other operations. The sleeve gastrectomy is a newer procedure that's being done for weight loss surgery. It's been around the United States for about 5 years. And basically what we do with the sleeve gastrectomy is we essentially remove part of the stomach. We make a long, skinny tube. So this pink part, this dark pink part, is the part that stays. And we actually go in and we staple off and we remove about 2/3 of the stomach, so you're left with this long, skinny tube. So how does it compare to the other operations? Well, about 60% excess body weight lost on average. So not quite as good as gastric bypass, but a little bit better than lat band. The average person stays in the hospital for 2 days. You have your surgery, you start a liquid diet on the first day after your surgery, and most patients go home the second day after surgery. And again, similar to gastric bypass, most patients can return to work in about 2 to 3 weeks. If you compare it to the other two, it's intermediate in terms of weight loss, as we said, and not surprisingly, it's intermediate in terms of the risks of surgery. And we'll talk more about those things in detail here in just a second. How about the outcomes? Well, diabetes resolves in 80%. Again, not quite as good as in the middle. Cholesterol about 60%, blood pressure 60%, and about sleep apnea about 95%. So it tends to be an intermediate type of operation. So when you're considering these operations, you have to understand that the surgeries, while they're very effective, as you can see by those numbers, they are tools to help people lose weight. They're not magic. So you still have to make lifestyle changes in addition to having the surgery. So if you just have the surgery and you don't make the lifestyle changes, you might lose some weight, but not as much as you want to or as much as you need to or enough to generally get rid of your health problems. So you have to make these lifestyle changes. We will teach you about these lifestyle changes. We'll teach you what you have to do. We've got a whole education process all set up and ready for our patients whenever you come through. However, if you don't make those changes, you're not going to have results you want. So amongst those changes are some dietary changes. And I'm giving this to you today just so you have an idea, well, what's life going to be like after one of these surgeries? How am I going to eat and how are things going to work? You'll meet with a nutritionist when the time comes if you decide to have surgery, and they'll go through all the details of this stuff. But I want to give you an overview so you know what am I getting into, okay? So dietary lifestyle after surgery. First of all, one of our rules is no liquids with your meals. The reason is when you eat food, and we do these restrictive operations, we want that food to stay in the stomach for a few hours afterwards so that you feel full for a few hours. If you eat and then you drink food and wash it down right away, you're going to lose that restriction and you're going to have difficulty controlling your weight. On the other hand, we have unlimited non-calorie liquids between your meals. So between your meals, you can drink all the non-calorie liquids you want. All the water you want, all the Crystal Light you want, for example. Diet soda is not good for you for other reasons, too much caffeine, and sometimes people don't tolerate the first few weeks after surgery. But yeah, you can drink all the diet soda you want down the road. But that's a choice you have to make. You're going to be on with all three of the operations for several weeks after your surgery, and it depends on which operation. You're going to be on a liquid diet for roughly a month, okay, roughly a month. And that's because when we do these operations, we've got to give time to heal before we start putting food through there and potentially stretching things and such. However, you will be able to eat solid food. You will be able to eat quote-unquote normal food. People say, can I eat normal food after this surgery? And the answer is yes. We want you to be able to comfortably eat a small, selected, solid meal. Now, you have to change how you eat that meal. Okay, so what's going to change? Well, the amount's going to change, but how you eat that meal is going to change. You're going to have to eat slowly, and you're going to have to chew your food very thoroughly for this to be successful and for you to be able to eat. So you can imagine if your stomach's only that big and you take a big old bite of a steak and you swallow it down without, you're going to have trouble, right? So we'll teach you the behaviors you need to do to avoid problems like that, but you'll have to make those changes. And the other thing is we want you to make healthy choices, and we'll teach you how to do that also. So if you're going to sit and eat ice cream all day, guess what? You're not going to have success because that will go down pretty easily. So we want you to choose high-protein foods because those are the types of things that fill you up. And again, we'll teach you how to do that. Our nutritionists will teach you that. All right, so we talked about the benefits of surgery. That's where all those numbers about the weight loss and the diabetes and all that stuff. And as we said, anytime you make a decision, you have to take the potential benefits of surgery and weigh that against the potential risks of surgery. So I divide the risks into two categories. The first category is risk that you see really with any of these surgeries or any major abdominal surgery. Okay? They would include death, pulmonary embolus, that's a blood clot that goes to the lung, dangerous bleeding, injury to the intestine or perforation of the intestine, pneumonia, infections, and hernias. Hernias are holes in the muscle that need to be fixed at the incision sites. The nice thing about this is, generally speaking, with the three operations, if we're done through the scope, that the risk individually of all these are less than 1%. Okay, so that's the good news. All right, then the individual operations have their own specific risks, and I'd like to talk a little bit about those as well. So let's start with gastric bypass. As we said, gastric bypass is the highest risk of the three operations. One of the risks, and one of the more dangerous, potentially dangerous risks, is a leak. So you remember that picture that we showed? We have to make two connections. In some people, those connections, they don't heal right. Even though we do the operation perfectly and we test to make sure it's airtight before we leave, a small percentage of people, it depends on the studies you look at, about 1 to 4%, depending on the study, they leak and it doesn't heal right, and that can cause infections. Now, sometimes those leaks can be real tiny things and they're not a big deal. We don't feed you for a little while, they tend to heal up by themselves. Sometimes they can be medium-sized, what I call medium leaks, where you get a little leakage around the connection, and a lot of times we can manage that without surgery. If you're stable and we do an x-ray and it's contained in that area, sometimes we can put drains in, give it time to heal up by itself. But sometimes, unfortunately, the leaks are spread through the abdomen and they're more dangerous leaks, and that usually requires urgent surgery to fix. We have lots of steps and precautions that we take to help prevent leaks and to detect them early, but even doing all those things, they still happen a small percentage of the time. Another potential risk is obstruction of the bowel, intestinal obstruction. So the intestine is a long loop of, like a hose, like a long hose. You have about 20 feet of small intestine all tucked inside your bowel, inside your belly there. And after these surgeries, you remember the picture again, we do a lot of moving of the intestines and sewing and making the Y shape and all that. And the more work you do on the intestines, the more risk of a blockage. What a blockage is a little kink somewhere along the line of the intestines. Lots of different things can cause it. Sometimes a little bleeding can cause it, sometimes a little scar tissue, and other things as well. The nice thing about these bowel obstructions, they can occur anytime after the surgery, but most of the time they can be managed without surgery. So of those 5%, only 1% of the time after these, does somebody have a bowel obstruction they need to be taken to surgery for, at least within the first several weeks after surgery. But again, that 1% of people do need surgery to fix these bowel obstructions along the way. Another potential risk is a stricture. Now, remember we were talking about that connection and the pouch at the top there. We make that connection small on purpose. We make it about the size of a nickel. And the reason we make it small is because, again, when you eat food, you want it to stay with you, not just drop all the way through to the intestine. So for most people, that's okay. But some people develop an overbuildup of scar tissue after the surgery. It usually shows up about 4 to 6 weeks after surgery. So that nickel-sized connection can scar down and narrow down so that sometimes it's very tight. And when that happens, of course, things won't pass through. You can't eat or drink properly, and we have to fix that. The good news about that complication is most of the time, we can fix that without a major operation. We can do an endoscopy procedure, outpatient procedure under some sedation. We go in with the balloon and we can stretch that connection out. And when we do that, the vast majority of the time, that solves the problem right then and there. Sometimes we have to go in for a second or third stretching. And sometimes, and this is very rare, we're talking less than 1%, the strictures come back to the point where the only way to fix it is to do another surgery to revise it down the road. But again, that's unusual, but it can potentially happen. Ulcers happen in different reports show different rates, but in my practices in the past, I've seen it about 9% of the time, these ulcers. What an ulcer is, it's a sore, it's an erosion of the lining of the intestine, usually occurs right at that connection. For most people, it's not a big deal because we can treat it fairly easy with medications. We'll usually get it to go away and get better by itself. It can show up with problems of coughing up blood or passing blood in your bowel movements, or sometimes pains, or even rarely with a perforation that needs surgery. But those are pretty unusual. Again, the nice thing is usually gets better with people without surgery for most people, except one group of people, and those are people who smoke after their gastric bypass. Okay, the risk of developing an ulcer after gastric bypass is 41 times higher in people who smoke cigarettes. We don't know for sure. It's probably the cigarettes have lots of bad effects. It could destroy the lining, but most surgeons think that it's because one of the things that smoking does is it destroys blood vessels, especially small blood vessels. So when you have surgery, you've already destroyed some blood vessels because of the surgery, and then you add this insult on top of it, and that's probably why. Okay? So they're very, very difficult to treat. So we do make sure that all of our patients, before any of these operations, you will have to quit smoking permanently. Okay? Because, again, for your safety, to avoid problems like this. Another possible complication is injury to the spleen. The spleen sits up real close to where we're working. We sometimes have to nudge it out of the way while we're working so we can get that pouch stapled off. And less than 1% of the time, there can be an injury to the spleen. When that happens, it causes bleeding. And a lot of times we can fix it without surgery. Sometimes the only way to fix it is to remove the spleen. Again, that's less than 1% of the time. The good news is people live fine without their spleen. If you take 10,000 people that we take their spleen out, so we know this from, say, taken out for car accidents and things like that, 9,999 out of 10,000 don't ever miss their spleen. Less than 1 in 10,000 have a problem with infections because their spleen's removed. So again, it's even unlikely to even need it done in these operations. So that's gastric bypass. Lap band, and again, these are the risks specific to the lap band. Stomach slippage. The band, we put the band around the stomach and we put some stitches in there to hold it in place. Sometimes what happens is some of the stomach underneath will push its way up through the band and you have too much stomach above the band. And that can cause problems with reflux or trouble keeping food down. That usually has to be fixed with surgery. That happens to about 2% of people. It can happen any time after the lap band procedure, sometimes weeks or usually months or years after the surgery. Again, it can be fixed, and it's not a terrible operation to have fixed. Usually requires an overnight admission. We do the procedure, we put the band in position, we retunnel it, we re-sew it, and that does the trick. Another possibility is obstruction of food. So as that band gets tight and you try to eat something, we'll teach you take small bites, chew your food. You take a big bite of something that doesn't go down easy, like a steak, or sometimes real thick breads will cause it, like a bagel or French bread or something like that. And food will get stuck there. And when that happens, the best way to not have it happen is prevent it, of course. When that happens, unfortunately, sometimes the only thing we can do is to have you come into the office, we take the fluid out of the band, we let the piece of food pass down, and then we could fill it up at a later date. Okay? Erosion of the band is an unusual problem, fortunately. It happens about 1 out of every 150 or 160 operations. That band is a piece of plastic. We put it around the top of the stomach there. We don't know why this happens. Different surgeons have different opinions of why it happens. But sometimes that band can cause a reaction or erode a hole in the stomach. When that happens, the only treatment for it is to remove the band completely and sew up the hole. Okay? It sounds like a terrible thing, a hole in the stomach, but since it happens over such a slow, long period of time, it's rarely a dangerous problem where you have to come in urgently to get it fixed. But when we have signs of it, infections in the port down here sometimes will cause it, or unusual pains will be signs of that, then the only treatment is to remove the band. It can be put in later on, 6 weeks or a couple of months down, it could be replaced, or more likely we recommend switching to one of the other operations. Swelling at where the band is. That happens to about 2% of people. In the first couple days after surgery, anytime you do surgery on tissues, they swell. Dangerous swelling or swelling where you can't get anything down past it happens to about 2% of people. Fortunately, it's not a dangerous thing. Usually we just put you in the hospital for an extra day or two after your surgery. The swelling goes down by itself, and then you can start taking liquids and get home. And then the last complication is a group of complications that I call port or mechanical complications. You have to understand the band and the whole system is a mechanical device. And sometimes there can be mechanical problems. You can get a crack in the tubing, for example. When that happens, we do your injections, but it leaks out, it doesn't fill the balloon properly, so it doesn't work. Or we sew the port to the abdominal wall, and the stitches can tear out, and the port can flip, and sometimes we can't stick it properly. When we have these mechanical complications, sometimes they require outpatient surgeries to fix, where we go patch the tubing or resuture the port. Overall, that happens to about 5% of people. Okay? So those are complications specific to the lap band. Then the risks of sleeve gastrectomy. Sleeve gastrectomy, again, intermediate in terms of dangerous complications. One of the things you can see with the sleeve gastrectomy is a leak. So where we've divided that, just like you see a leak at the connection, where we divided the stomach to remove it, sometimes that staple line doesn't heal properly, and that results in a leak with similar problems to the gastric bypass. That happens to about 1 to 2% of people. When it happens, sometimes it requires surgery to fix, sometimes it can be managed without surgeries or with scopes and things like that, but sometimes it could take some time, weeks or even months to fix. But again, it's unusual, about 1 to 2%. And then the other risk is a stricture. A stricture is a narrowing. And so when we make that long, skinny tube out of that long, skinny sleeve, sometimes it can develop narrowing, lots of different reasons why it can happen. But when that happens, food won't pass through it properly. And again, that has to be fixed. Sometimes it can be fixed with scopes, where you go stretch it out. Sometimes requires surgery to fix. So that's 1% of the time. And so if you add that all up, it's about 2 to 3% of the time. Now, one of the nice things about sleeve compared to the other operations is, yes, these are serious risks when they happen, but you don't see much else on here. So down the road complications, if you get through those first couple of weeks or a couple of months after surgery without a problem, down the road complications are unusual with the sleeve. All right, side effects. And the side effects are pretty consistent with all the operations. Nausea and vomiting, you're going to have some, right? We're going to change how you have to eat. That takes some practice. That takes some experience. That takes some education. You're going to have days where you don't do so hot, okay? It may be for different reasons. Maybe we'll teach you how to avoid these things, but some people, hey, they don't really follow instructions as we tell them to. Or some people, they don't understand the instructions sometimes. That's when they need extra teaching. Sometimes just stress gets to them. You know, we don't always overeat because we're hungry. Lots of time we're overeating because we're dealing with stress, anxiety, and those other things, and that gets the best of you. So you eat too much, you eat too fast, you have a bad day. So you will have some nausea and vomiting along the way. I've had patients that, you know, had these operations. They said, I never threw up once. I have patients that said, well, I threw up every day for the first couple of months until I really learned how to eat properly. Difficulty swallowing, we call that dysphagia. That's food getting stuck or going down with difficulty. As we mentioned, with some of those harder foods, you have to chew up very, very well to avoid that. Gall stones. As you lose weight rapidly, your body has a tendency to make or to form gallstones, okay? And that's true even if you lose weight without surgery. About 2 to 5% of people, that they lose the weight and their gallbladder starts to act up to the point where you have to take your gallbladder out after the surgery. Pregnancy is not, I've got a list here, it's not really a side effect of the surgery. You won't get pregnant because you have, especially the guys, you won't get pregnant because you had the surgery. I put this on here because you have to watch that. If you're a female of childbearing age, okay, we don't want you to become pregnant for at least 18 months after your surgery. During that period of rapid weight loss, we don't want you to be trying to nourish a baby. Okay? It's not safe for the baby. It's not going to be harmful to you, generally speaking, but it may not be safe for that baby that's developing. So for those 18 months after surgery, we want you to prevent pregnancy. Prevent pregnancy. Now, there's a difference between somebody who says, I'm going to prevent pregnancy, and somebody says, hey, man, I hope I don't get pregnant. Okay? Does everybody know what the difference is? All right. Okay, so there's 18 months you have to prevent pregnancy. Vitamin mineral deficiencies. And depending on, and it tends to be very, very infrequent with the lap band, very infrequent with the sleeve, and unusual or infrequent with the bypass. But vitamin or mineral deficiencies, because your stomach aren't as big, you're not absorbing those vitamins as well necessarily, you will need to be on some vitamin supplements every day for the rest of your life. Now, it's nothing fancy or expensive. You know, some programs you'll go to, they'll tell you, you got to buy our vitamins, it's $30 a month. That's not necessary. Usually, our nutritionists will explain it all to you. We want you on calcium supplements, we want you on multivitamin with iron supplements, and B12 either in the multivitamins or separately. Protein malnutrition, it's unusual. Dangerous protein malnutrition, not getting enough protein in, is very, very rare. It's almost unseen with the lap band. If you have those problems, you just let the fluid out, people do okay. It's unusual with the other two operations, but it's something we keep an eye on. So one of the things that will happen is if you have one of these surgeries with us, we're going to want to be your bariatric surgeons forever. We want you to come back and see us regularly, do different operations at different intervals, to look for and to help look for these vitamin deficiencies, protein malnutrition problems, or these, or to, you know, if you're not losing weight as we expect you, there's some more teaching and counseling and things. Excess skin is another side effect. So as you gain weight, the skin, of course, grows with you, right? But as you lose weight, it unfortunately doesn't just shrivel up and go away. It tends to hang or sag. For most of our patients, it's a cosmetic issue. In other words, it's not a medical problem. Some people, it is a medical problem. These are usually people who are starting at some of the real high weights. And what happens is the skin can hang down so badly that you get rashes underneath, or sometimes really big people hang down to their knees, they can't walk properly or cover their privates, and they have trouble with that. In those cases, insurance companies will usually pay for skin removal surgeries. But in the case where it's just a cosmetic thing, insurance companies, they generally, not some are different, but they generally don't want to pay for those surgeries. So you can have them done, but you might have to pay out of pocket if you're doing it just for cosmetic reasons. So, told you all about the 3 operations, and then the next question I'm always asked is, well, Dr. Rowitz, which operation is the best? Well, that's a tough question, because again, there's advantages and disadvantages of each operation. When I came to Carle, I've only been here about 6 months, My associate, Dr. Oliphant, I watched him give one of these seminars, and I think he put it best. He said, if I were going to ask you which car is the best, is a minivan the best, or is an electric sedan that gets 40 miles to the gallon the best car, or is a sports car, Corvette? Which of those is the best car? The answer is it depends what you're looking for, what you're looking to get out of that car. And that's the same thing with these surgeries. There are some factors that I think you ought to consider, though, between these surgeries. First is your BMI. The heaviest patients, when your BMI gets above 55, 60, 65, even 50, some people would argue, they need the more aggressive operations. I generally lean towards bypass or sleeve in those patients because with lap band, they tend not to lose the type of weight that gets to them a healthy body weight. So that's one thing to consider is how much is your BMI. On the other hand, your overall health. So how much risk is this surgery to you? So if you're high-risk surgery, and we'll talk about those things when you come see us in the office specifically, then we might lean towards a less aggressive operation the number one priority has to be able to get you through the surgery safely. The procedure risks. So that's another difference between the three operations, as we said. Both the short-term risks, the risk of dangerous complications in the short term, but also the long-term risks. And again, we talked about some of those earlier. Procedure outcomes, those are the numbers we gave you. Some operations, there's a spectrum of effectiveness. Those are things you need to consider. And then the follow-up schedule, and this really comes, you have to follow up regularly for all three of the operations, but this really comes into play with the lap band. Because with the other operations, yeah, we're going to see it pretty frequently at first, but as things level out, we'll see every 6 months or so down the road. Okay? But with the lap band, for the first couple of years, we're going to need to see you about every 6 to 8 weeks on average because we've got to make decisions about tightening those bands. And you need to follow up with those appointments to be successful. So that is another difference. So those are all things to consider when you're choosing which operation. Some people, I'll tell them, this is really the operation you need in my opinion. But for the vast majority of people that come in, I'll say, any of these operations will work for you. Which of these issues are most important to you? And so we can sit down and come and make a decision about which one. All right, one thing I do have to tell you, surgery is not an easy way out. Okay? Some people, they tell their friends, oh, you're just taking the easy way out. Anybody heard that one before? Okay? Sometimes people even think it themselves, I'm just taking the easy way out. I'm here to tell you it's not easy. Okay? It's effective and it works, but it's not easy. So why is it not easy? Well, first of all, you have to make lifestyle changes. We talked about it. You have to diet and exercise for this to work and be successful. Now, sometimes people say, well, geez, Dr. Rowitz, if I could diet and exercise and stay with it, why do I need the surgery? I wouldn't need the operation. Well, that's not necessarily true. Okay? These surgeries offer a couple of very important things that just plain diet and exercise don't. All right? The first thing is we talked about with the sleeve and the gastric bypass, some of the hormonal changes that lead to hunger. Okay? You don't get that if you're just on a regular diet. The second thing is, because these operations are restrictive, all three of them, you will feel physically full after you eat. So when you eat a meal, and even though the portion size is only that big, you will feel physically full. Whereas with a diet, if you're depriving yourself of calories, you don't get that stretch of the stomach. And so you don't get that physical fullness. So that's another thing that the surgeries provide that regular diet and exercise don't. Another thing is negative feedback. So let's say you're having a bad day. You're stressed out and you want to sit down and go to the refrigerator and there's, whatever your comfort food is. And you want to sit and you want to pig out. Okay? Well, if you've had one of these operations and you try to do it, what's going to happen? You're going to get negative feedback. You're going to feel bad. You're going to get sick. You're not going to be able to, right? However, if you've had a diet, you're just on a diet without the surgery, what's going to happen? Well, you can do it. And you have trouble, and you get those calories in, all right? And then I think the other thing is, obviously, the difference is the surgeries work. The studies show these surgeries help people lose weight, whereas that's not the case with just plain diet and exercise for the vast majority of people. Another reason it's not an easy way out is the emotional issues. So we talked a little bit how because sometimes we eat because we're stressed or we're anxious and such. Well, we use food as a coping mechanism a lot of times. The problem is after these surgeries, we're going to take your coping mechanism away. Now, unfortunately, I can't take the stress in your life away. I don't have an operation that's going to fix the stress in your life. I wish I did, okay? All right? but I'm not going to be able to fix the stress, but we're going to take your coping mechanism away. So most people go through a rough time those first several months after. The first 3 months after surgery can be very difficult. They get a little bit down, they get a little depressed, they get a little stressed out. Their spouse will tell you, hey, you're kind of hard to live with right now, so anticipate that's going to happen. But afterwards, as things start settling down, they get used to the new eating habits, they're seeing great results with the weight loss, then that all tends to get better and go away with time. Okay, but it is rough for a little while. There's some discomfort. Okay, that's another reason it's not easy. Hey, you're having surgery. It's not terrible pain, especially with the laparoscopic operations. But yeah, there is some discomfort. There's some discomfort when you eat. We talked about the changes in the new habits, right? Some discomfort there. There's just some discomfort in your lifestyle and your time. You got to add time in your life for exercise every day for this to be effective. You got to stretch your meals. That's going to take time in your life, right? Extra time in your life. You got to come to the office for your follow-up appointments. You got to come to the office for your nutrition appointments. You got to come to the office for your pre-op appointments. How many people are missing time from their life right now to be here today? Well, obviously everybody is. So you have to take some time too. There's some discomfort from that standpoint. And then of course the other reason it's not easy is because of the risks and the side effects that we talked about and covered before. Okay? So who's a candidate for surgery? Well, first of all, you have to meet the NIH, that's the National Institutes of Health weight criteria, and that was put forth in 1991. And that's the stuff I just talked about, BMI greater than 40 or between 35 and 40 if you have one of the life-threatening health problems. Diabetes, high blood pressure, cholesterol problems, heart problems, or sleep apnea. You have to be an acceptable operative risk. We have to be able to get you through the surgery safely. Okay, again, that's that risk benefit. So for example, if you're 80 years old and you had 3 heart attacks and your last heart attack was yesterday, are we going to be able to get you safely through that operation? I would worry a lot. We wouldn't recommend it. That's an exaggerated example, but we take every patient individually, look at their potential benefits, we look at their risks as we try to make that decision. You have to be able to understand the surgery and the risks, and it should say on this slide, but you also have to understand the aftercare. So you have to understand what you're getting into, but you have to understand how to take care of yourself afterwards. We'll teach you, but if you don't understand it. So who's a candidate for surgery? Well, first of all, you have to meet the NIH, that's the National Institutes of Health weight criteria, and that was put forth in 1991. And that's the stuff I just talked about, BMI greater than 40 or between 35 and 40 if you have one of the life-threatening health problems. Diabetes, high blood pressure, cholesterol problems, heart problems, or sleep apnea. You have to be an acceptable operative risk. We have to be able to get you through the surgery safely. Okay, again, that's that risk benefit. So for example, if you're 80 years old and you had 3 heart attacks and your last heart attack was yesterday, are we going to be able to get you safely through that operation? I would worry a lot. We wouldn't recommend it. That's an exaggerated example, but we take every patient individually, look at their potential benefits, we look at their risks as we try to make that decision. You have to be able to understand the surgery and the risks, and it should say on this slide, but you also have to understand the aftercare. So you have to understand what you're getting into, but you have to understand how to take care of yourself afterwards. We'll teach you, but if you don't understand it, then you're not going to be able to do it successfully. And lastly, you have to be dedicated to lifestyle changes and follow-up, long-term success. You got to do the things that we recommend, and you have to follow up with your surgeons to keep an eye on things. Who's not a candidate? First of all, some previous operations on the stomach. When you operate on the stomach, when you do an operation anywhere part of the body, you develop scar tissue, and that makes any reoperations more complicated. There are some operations that myself and my associates have said, you know what, that's too risky. The outcomes are too bad when you try to do these operations and over some of these other gastric operations. Understand, gastric operations, stomach operations, those are different than abdominal operations. Most abdominal operations are okay. So if you had your hernia fixed or you had a gallbladder operation, your appendix out, hysterectomy, all those are okay. But if you had surgery on the stomach itself, sometimes we'll tell you it's not safe to have surgery. Uncontrolled psychological conditions. So if you have very serious psychiatric problems that you're battling with, then sometimes we're going to say, hey, this is too dangerous for you. Because we talked a little bit about the stress after the surgery, the emotional problems. If you're already struggling greatly and we add that extra stress, then that can become dangerous. Now let me talk a little bit about depression, because depression is very common in people who are battling their weight. If you look, some studies show as many as 90% of people who are battling this problem to this degree are battling depression as well. So most of the patients that come in and see us, they're battling depression to some extent. Depression does not exclude you as a candidate for surgery, but we do have to do some things. We want to make sure your depression is controlled. So if you're seeing somebody, you're on medication, things are under control, hey, no problem. if you tried to commit suicide yesterday, right? And I'm exaggerating again, then now's not the time to have a major surgery like this. Active alcohol or drug abuse, well, you got to beat that first. That falls into the previous categories, uncontrolled psychological conditions. So you have to beat those habits before we can consider you as a candidate for surgery. To compound it even further, the problem with alcohol is what? Calories. So if you're drinking 4 or 5 or 6 beers a day, you're going to drink those calories in, and these surgeries aren't going to work anyway. Active smoking habits we talked a little bit about, right? You've got to quit smoking before we'll consider a surgery for you, for a couple of reasons. First of all, the #2 cause of preventable death in the United States is obesity. #1 is smoking, right? So think about it. Why do we do these operations? To help you live longer and healthier. If you're going to keep smoking, you're going to be at high risk anyway. It's not worth putting you through the risks of surgery, okay? The other thing is we talked about the ulcers as complications after bypass. There's lots of other complications. I don't want to get into run a whole list. But your risks of surgery go up higher if you smoke cigarettes at the time of your surgery. If you quit as little as 6 weeks beforehand, that can start reducing your risks. So you need to quit smoking. And then the last thing is a history of medical noncompliance. So if you're the type of person, you don't show up for your appointments, you don't do what your doctor tells you to. Your doctor tells you to get your prescription fills. You don't get it. He orders a test. You don't show up for the test. Then this stuff's not going to work for you. We don't recommend surgery. So if you're not going to follow directions or instructions. All right? So that